about driving AI innovation in healthcare with modern data foundation. With us, we have Alexandra Flat, who's an Executive Vice President, Health Systems Intelligence, Data Governance and Analytics at the Provincial Health Services Authority. Alexandra?
Thank you. Thanks.
Wonderful.
Thank you.
Like mid-afternoon, so everyone's just kind of
To start a presentation, I feel totally relaxed. Thank you very much for the opportunity to present today. My name is Alexandra Flat. A lot of people know me as Lexi, so feel free to call me Lexi. And I'm the Executive Vice President for Health System Intelligence, Data Governance and Analytics at the Provincial Health Services Authority in British Columbia. And I'm here today to talk to you about how we are using a modern-day foundation, or trying to use a modern-day foundation to drive AI and innovation, really innovation in healthcare. So I just need my PowerPoint up, if it's possible. And maybe while it's waiting, I'll just jump into the presentation. What I wanted to start with was just to give you a bit of an explanation around who PHSA, or the Provincial Health Services Authority, is. It's out of British Columbia. British Columbia has 5.5 million people, and we serve really all of British Columbia, but really in terms of specialized healthcare services and care. And so we have 29,000 staff, 1,900 medical staff, and then we have a budget of about $5.2 million, or $5.2 billion. And we have a focus in 4 primary areas. I'm just waiting for that to come up. It's clinical policy. So in terms of clinical policy, we provide care for provincial programs like cardiac care or transplant care, renal and lab services. We have clinical service delivery areas like Children's and Women's Hospital. We also provide cancer services for all of British Columbia. We have the ambulance services. We are the largest ambulance service provider in Canada, and we provide about 500,000 events, care to about 500,000 events per year. We have mental health and substance use, as well as the BC Centre for Disease Control, which is really was at the center of the COVID response. Are you okay in finding my presentation? You're working on it? Okay. And then we also have a focus on commercial services. So we do supply chain and procurement. So for supply chain, we provide about 350,000 products to all of our healthcare providers in the province every day, and we manage about $10 billion worth of products in contracts every year. So we have quite a big program or service offering there. Thank you. Going to skip to just a bit about our data complexity then for some of the data nerds out there. We have some very small data systems and very large data systems. Our clinical system is Cerner, for any of you who have a clinical patient system. And just to give you a sense, within Cerner, there's about 7,000 tables in Cerner, and we access about 60 of those 7,000 for secondary data use. So a lot of untapped potential there. We have online services such as Salesforce, and we have a variety of different types of data, both structured and unstructured. And on the unstructured side, it's, as you might imagine, a lot of physician clinical notes and other types of notes. In terms of the volume of data, we have about 100 and plus source systems, 20 plus terabytes of raw data, and 50 billion plus rows of data. We have both images and documents in terms of our data. We have real-time data feeds, we have batch extracts, and we have some data that is updated on a continuous basis, like our physician billing data. Like any data set, we have many types of data entry errors. We have lots of free-form text fields, which creates problems for us. And we do have some clinical standards which are largely adhered to. So why is data so important to us? I mean, we're in a point in time where there is some urgency for us. Healthcare is facing a number of different challenges, and we need help. And so people are looking for data and analytics to help to provide some solutions. I wanted to just spend a couple of minutes to give you a sense of the landscape that we're dealing with. So the first issue is life expectancy. So for the last 4 decades, Canadians in general have seen our life expectancy increase. If you look at the top line in that graph, that's women. Yay, women. We've been exceeding men in life expectancy for some time now, but men have been catching up. But you'll see in the last couple of years, in 2020 and 2021, life expectancy actually dropped, and that's the first time that's happened since 1921. And largely, some of it had to do with COVID. We certainly saw some excessive deaths as it related to COVID, but more specifically in British Columbia, it related to the illicit drug toxicity. In British Columbia in 2023, we actually set a record, an unfortunate record of more than 2,500 lives lost to the illicit drug deaths. And unfortunately, this is happening among our males, and it's happening among young males, with 80% of our deaths among men and between the ages of 20 to 49 years of age. We're also seeing declining mental health. We heard that in the last presentation. Canadians in general are saying, I feel pretty healthy, but if you ask them about their mental health, generally their mental health is in decline. And you can see from the graph there, the light blue line really trajectorying down. That is our youth between the ages of 18 to 35 years of age. And predominantly what they're talking about are anxiety and mood disorders. And a lot of individuals who have anxiety and mood disorders, they're indicating that they're not getting the services they need to manage these issues. We're also seeing disparity in outcomes. British Columbia is home to 204 First Nations communities. It represents 2% of our population, and we're seeing quite a number of safety and health inequities among our First Nations communities. The graph on the left, I'll just take the first one, emergency room. We have over 70% of First Nations, when they come to the emergency room, say they feel unsafe in our emergency rooms. Non-Indigenous people, less than 45%. I think the middle graph is really telling. If you look at every single age group and you compare First Nations and Métis populations against non-Indigenous populations, they have a significantly higher proportion of 5 or more health conditions at every single age. And so these disparities in health exist from birth all the way through to death. And finally, in terms of the illicit drug toxicity crisis, we are seeing that our Indigenous population are dying at a higher rate than our non-Indigenous. We're also seeing increasing wait times. There's a decreasing percentage of Canadians who are treated within benchmark timeframes for joint replacements, so your hips and knees, as well as cataract surgery. In our emergency departments, if you happen to have been to an emergency department, I'm sure your wait was longer than you wanted it to be and probably felt longer than it has been in the past, and we know this is true. And we're also seeing in our rural and remote areas, it's in the newspapers in British Columbia, that we are going on lengthy diversions because we don't have staff to even staff our emergency departments. And then coming out of COVID, a lot of family docs, they were using virtual care, but they've continued to use it, and we're still seeing a higher proportion of virtual visits to inpatient visits in our primary care settings. And then I think the one thing that we're seeing globally is that there is a healthcare workforce crisis. In 2021, we saw the highest number of retirements among our healthcare sector. 1 in 7 Canadians are reporting that they don't have a healthcare provider. And if you do have a healthcare provider, a lot of people are saying, well, it takes me 3 months to get in to see my GP. And almost 2.5 million people are saying that they are not receiving the care that they need. So our health system is really, the quality of care is really in retreat. And what are we doing about it? And how can we actually use data? How can it be a foundation to improve our quality? Well, when COVID hit, we were still on-prem, and that was really as it relates to privacy issues. We weren't allowed to move into the cloud, but when COVID came, the crisis came, there was actually a real shift to kind of make data and information more quickly available, and so we quickly moved into the cloud. And as a result of it, we created our platform, the PHSA, what we call Panda platform, which is a platform for analytics and data. And the Azure, we went into the Azure infrastructure, and we quickly found that the Azure infrastructure created agility and independence for us. And this was particularly true when it came to our IT counterparts. So, if we needed to increase capacity, if we needed to scale up, if we needed to, add a server, it was very easy for us to do. And just the ability to process data, the ability to analyze data was just something that we never had experienced until we moved into the cloud. It also really transformed our analytics. We just didn't have the tools or the ability to do the things on-premise that we could do in the cloud. And so that was just enormous in terms of data processing, in terms of machine learning, and even as we moved into OpenAI type of projects. We've now moved our data into a central zone, and all of that central zone data is linked, and it has defined cohorts. And this really allows, and I'll show you some more information, or some more slides later on, it's really allowed us to bring data together around a patient to really understand the patient's life history and where, what might happen to them into the future. It's also, this architecture has really helped us from a data governance perspective. We've really been able to develop an enterprise data governance. I heard this morning where people were talking about having not a lot of resources for data governance. I would say that continues to exist in our organization. It's something that we're interested in and important to us as a healthcare provider. But there's not a lot of resources to go around for those kinds of services. And sharing of data continues to be a problem in this architecture. So when we want to share data with our partners, we still have to physically move that data. So this is really the scope of Panda, and this is what we're trying to build is a patient longitudinal record from cradle to grave. And what we're trying to do is really piece together all of the data assets of a patient for the patient, what happened to them and how can we predict what might happen to them into the future. And so we're gathering data from surveys, we have registry data, we have public health data, of course ambulance data, we have administrative and operations data, we have clinical data, we're trying to pull in more of our research data, and we have a lot of diagnostic type data. This is a massive undertaking to try to pull this all together at the patient level. So how is our data foundation driving change across PHSA? Well, we're currently using large language models really in the back office space and really trying to drive efficiencies in the back office. We're starting to use machine learning for imaging interpretation. We're using clinical decision support tools to predict deterioration in our ICUs, and we're hoping to get into the space of deep learning, but we're not there yet. So what I want to do is just provide you some really practical examples of how we're using this data and where we're going to. So the first is with regards to AI-driven timely cancer data. So as a cancer system, we are required to submit data to the international bodies, and it's quite a bit of data that you have to submit on every single cancer patient. And traditionally, that data is like 2 years. So 2 years go by, we submit all the information on a patient to this international body. And we realized that this data holds an immense amount of information, and it's useful for this international body, but it was more useful for our planning and evaluation, as well as in terms of clinical decision-making. And so we made a real effort to try to move this to more timely data that we could use more ongoing. So this was a fairly substantial undertaking. We have over 30,000 new cancers diagnosed every year. We have tumor registers that go through over 1 million clinical documents to identify those 30,000 cancers, those 30,000 cancer patients, and all of the associated information with those patients. There's quite a number of international coding rules that they have to follow, and it takes quite a bit of time to process, to understand, and to report out on these patients. In addition, tumor registrars are in decline. It's not a field where people are going into, and so they're hard to come by. And so we actually worked really closely. This concept of human in the loop starts right when you're starting to develop your tools and your pipelines, and we actually worked really closely. Their unionized staff thought we might have some anxiety. They might have some anxiety in working with us, but it actually was very rewarding. We took out the work that they didn't want to do, and we were able to give them more time to do the work that they wanted to do. We have used NLP and AI with human in the loop in order to make our data real time, and it took us about 2 years to do it. I'm very proud of the work that we did, and it's something that we now use on an ongoing basis. We're also generating 3D head and neck PET images. So if you want to develop an AI-assisted disease diagnosis system, it requires a significant amount of data, especially for a 3D image and for diagnosis. And it's quite challenging if you pick a diagnosis where it's a small number of cases, so you don't have the volume of data to create your model, and you don't have a radiologist, for example, who's willing to supervise and annotate the data. So what do? How do you start to move into that space? Well, we looked at generating synthetic data as a possible solution. And so what the synthetic data does is create enough diversity in our data to allow us to then to train an AI model. And so what we did was create 201 synthetic data images, 201 synthetic images, and compared it to 201 real images. And we had a panel of radiologists do that, and they were undetectable. They were unable to tell the difference between the synthetic and the real images. The synthetic images are the ones on the top, and the real images are those on the bottom. And what's great about this now is now we have a data set that we can now feed into, try to train a system to develop an AI-assisted disease diagnosis. We've also used it in our emergency health services. So last year, we were looking at rotary wing resources and trying to figure out how we could enhance or improve our rotary wing resources. On the left-hand side is our scene response demand. And what we did was just project out what we thought our scene response demand would be for our 4 rotary wing resources. So anything in a darker orange color means we have an auto launch. We're predicting a higher auto launch demand. Anything in a lighter yellow is less demand. And an auto launch occurs if you have a motor vehicle accident or a trauma, and that occurs more than 30 minutes outside of a tertiary trauma center. We are required to send a rotary wing resource to respond. So what we were trying to do was to have our response time for on-scene response within an hour anywhere in British Columbia. And so what we looked at was adding 2 more resources, one in Prince George in the north, one in Qualicum in the south. And you can see on the right-hand side that we have fairly good coverage. There are pockets of the province that we don't cover very well. But we had a second proponent who had bid some new helicopters, and the same helicopters the helicopters in the same places really increased our coverage quite substantially. So you'll see there's still areas that we're not able to cover, but this new proponent helped us to evaluate our options. So while this data infrastructure has really helped us and given us the platform to really take off and help our programs to really move our forward and to improve the quality of care across British Columbia, we are looking into the future, and we are working with Microsoft to really push Fabric throughout our organization, and we think that there are some real advantages to using Fabric, especially around having all of our services under one umbrella. We think that will provide quite a bit more opportunity for our programs to really work end to end. So this is going to take a little bit more restructuring. We kind of knew Fabric was coming, but it's still taking us some time to really get our data into the zones from raw data to semi-transformed to transformed. But we're making our way through there, and I'll show you a proof of concept that we're working on. We really think that the advantage from our perspective is on the structured or the unstructured data. So the clinical notes and the images are largely untapped in healthcare, especially in the Provincial Health Services Authority. This will really give us an opportunity to tap into that. But also, it's really going to give us an opportunity to share data more easily across our programs and our partners. The opioid data, as an example, the BC Centre for Disease Control created that cohort. That data can now be shared with mental health, it can be shared with public health, it can be shared with emergency health services. They'll understand the data lineage, where that data came from. And so that concept of really understanding the patient and understanding the data that's attached to that patient over time, that's really what this is going to allow us to do. We have had some challenges in modernizing, so it hasn't been a completely smooth process. So some reluctance to change. We have about 300 to 400 types of analytic data and analytic people in our organization. And we have set up some communities of practice, like an R and a SAS community of practice, but we don't have expertise in things like Spark or Notebook, and so how do we start to build and get people into changing and the change that they need to do? We do have integration issues, so we share our tenancy with 6 or 7 other legal entities, so other health authorities. So if we want to make a change, like something like make our Power BI public, we have to get agreement from all of our other partners, other legal entities. And so that's a bit frustrating. So we're trying to work with Microsoft, and they're working on trying to change some of those decisions at a lower level. In terms of building flexibility, as I said, we have some very small data sets and some very large data sets. And we want the workflow to be efficient no matter what kind of data set you're working on. And we have staff who come to us and say, hey, like I don't have a Facebook-sized data set. Why can't I just work on my desktop? I don't want to go into this big infrastructure and change the way I do my work. And we're also seeing rapidly evolving technologies, and it's hard to keep up with it. It's impossible to keep up with it. And even if you do keep up with it, that technology may not be around any longer. We're getting a chance to try new technologies. You might get used to it, and then it may be dropped. And so that can be frustrating sometimes. And finally, as a public sector, budget constraints are a big factor for us. We are trying to promote a learning health system. We have in total over 30,000 employees. So, how do you really try to get data and analytics and have more self-serve when you have that many staff and you have soft funding? And the whole concept of moving from capital funding to more operating funding is really a big change in how you set your funding structures up. So next steps for us, we're right in the process of implementing a proof of concept, and we decided to choose sexually transmitted infections as our area of choice. It's not great for Microsoft for promotional material, but that's the area we decided to focus on. Syphilis is a sexually transmitted infection that we're looking at, and the syphilis has actually increased quite substantially. In 1 year, the number of cases increased by about 25%. And what's different about it now is that you're seeing it more in different populations. So we're seeing it a lot more in women and women of childbearing ages. And that's quite concerning for the babies, for the infants, because congenital syphilis can cause death to the infant or serious lifelong impacts to their life. And so this is a highly preventable and treatable disease. If we can identify these people early on, we can prevent these serious outcomes. So what we're doing is we are looking at an end-to-end data capture where we're planning, implementing, and evaluating congenital syphilis reduction interventions. And so the first piece that we did was we organized all of our data into that medallion architecture, so all of our public health data, our clinical care data, and our perinatal type registries. We then have been building our pipelines to serve many different needs, and we're using very large data sets to do that. And by doing this, by integrating all of these very large data sets, it's allowing us to do some outcome assessments. First, to look retrospectively back into a patient's life. What are the things that led them to where they are? But hopefully, in the future, prospectively to prevent congenital syphilis from occurring. We have started to consider looking at using NLP tools, so we're exploring this already on some of our unstructured data to try to see whether there's patterns in there, like instead of looking at postal code, looking to see whether or not in the unstructured data, is there mention about housing or homelessness? There may be populations in which we're seeing more congenital syphilis, where if we can target those populations, if we know where they are, we can provide some services to community groups and community agencies around there. We're also looking at building apps for notifications and messages to patients or to community groups or to providers. And because we're a public health system, we have those connections built in place. And then finally, we're really hoping that we can use this as an opportunity to generate synthetic data. And really here, the purpose of this synthetic data is to really get rid of the patient identification, which is a problem for us, for researchers. And so if we can use the synthetic data so that researchers can then look at our data and create more innovations, that's ideal for us. Creates a low risk. So I just want to thank you very much for allowing me to share our story with you. We're really excited. The amount of data that's out there on your phones, everywhere around our health is limitless. And our ability to really impact human life, both quality of life and quantity of life, is really powerful and what drives me in my job. So thank you very much for the opportunity today to share our story.
Thank you so much.
I think everybody have
I would think we would have a lot of questions on the topic. Who wants to start?
Thank you so much. It's a great presentation, a lot of insight. What are you doing? I have a specific question related to fabric. We are also planning to have fabric in our ecosystem. Did you already started the work? Are you facing any challenges? What is the plan? When are you going to roll out? If I ask you, is it a few months or is it going to take a year?
I don't think it can take us a year. We have some fairly substantial problems that we're trying to deal with. And we have had some experience. We've done some work with Fabric already in a proof of concept. We've been working closely with Microsoft, are looking to get some support. Our hope is that we'll have something in about 3 to 4 months that we can share. There's a specific, another proof of concept that we're working on is on breast imaging. And it's something we don't have time to spare. We have a lot of women who are not being diagnosed quickly enough, and so we're looking at Fabric as being a solution to help us to bring those data assets together. So yeah, there are lots of issues. We did have our data really well organized to begin with, so we knew we were well positioned to move into Fabric, so I think that helped us. But yeah, I think 3 to 4 months is sort of our timing. I'm not sure my staff would agree, but that's what I'm pushing for.
Thank you for your questions. Thank you. It's so great to hear from our health officials talking about what they're going through and the transformation that comes. It's not easy. We're quite sure even private companies have a lot of challenges, so it's great to see you're on the right path and doing a lot of good work. Thank you.
Thank you.